So I don't have any disclosures related to this talk. So my goals to start is to just review the role of radiation very briefly for rectal cancer and then describe the use of short versus long course. Then we'll talk about how and why total neoadjuvant therapy has arrived to stay, and then describe the further evolution of that into non-operative management. So, of course, we all know that the traditional role of radiation for rectal cancer is in the setting of T3 or higher disease or node-positive disease, and that radiation in that setting, in this traditional setting, is not felt to improve overall survival as long as a standard of care total mesorectal excision surgery is happening. And so our role in that historic sense is really to just help improve local control. So we want to reduce local recurrences and help sterilize downstage for our surgeons. And of course, that comes from the Dutch trial historically, where we showed that adding radiation to a TME didn't produce an overall survival benefit, but did reduce local recurrence by about half. So that is in the pre-op setting. So why not do post-operative radiation? It's, you know, a historic question. You have all of the pathology information. It seems very tempting. But we know from the German trial historically that if we compare preoperative versus postoperative radiation, the outcomes are poorer with postoperative treatment. Not only is local recurrence not as good in the post-op setting, but also toxicity is significantly worse in the postoperative setting. And I don't have it circled here, but one of the more interesting things to consider is that in patients who are felt to require a permanent ostomy up front or an APR resection, preoperative radiation, of course, allowed more sphincter sparing by downstaging some of those patients. So sphincter sparing was better preoperatively. So the long-standing United States and NCCN recommendation has been to give neoadjuvant long-course chemoradiation, which looks like this, of course, we all know, followed by a break for recovery, surgery, and then adjuvant chemotherapy as soon as patients are medically able. And that adjuvant chemotherapy is actually extrapolated mostly from the setting of colon cancer. The randomized data for adjuvant chemotherapy in rectal cancer are somewhat lacking by comparison to the colon setting. All of this, of course, takes a very long time for patients to actually get to the initiation of chemotherapy. Optimistically, 4 months or so from initial diagnosis, assuming that everything moves in a very streamlined fashion. However, at WashU in St. Louis, we favor doing preoperative radiation that is short course in style, which is 5 gray times 5. It's a very common regimen in Europe, but in the United States, actually most centers still use long course chemoradiation, which is acceptable in terms of oncologic outcomes, but is logistically more challenging for patients. And so that often raises the question, at least in the US, of is short course as good as long course radiation? And probably the cleanest evaluation of this is the Trans-Tasman study, which looked at neoadjuvant short course versus neoadjuvant long course chemoradiation. Surgery happened in a delayed fashion, 4 to 6 weeks. There was no difference in the study in overall survival. And late toxicity, which is often a concern of surgeons in particular with short course, was actually not different, nor was local regional failure statistically different. So the answer, at least from this nice randomized trial, which is our best data, is that yes, short course is acceptable. The question of when to operate after short course does sometimes arise because in it, historically, the timing of surgery has been often immediate. Generically, after the Stockholm 3 trial, the answer is that we should be operating with a delay after short course treatment, 4 to 8 weeks after radiation completion. So this study randomized patients to a short course followed by surgery within a week of finishing, short course with a delay to surgery, and then long course radiation with the same delay before surgery. And they were oncologically equivalent, but postoperative complication rate was less with delayed surgery after short course radiation compared to immediate operations. So if you're doing short course radiation, ideally you want to be, for most patients at least, delaying until surgery. And so there are some considerations for when perhaps to not use short course radiation. And one of those is in the setting of clinically positive inguinal nodes. This is technically metastatic disease, but we often do still treat these patients definitively. And there's not good safety or toxicity data on using what are often 3D conformal radiation treatment plans to cover this larger field area and more potential for skin toxicity. Another potential caveat is in the setting of extensive anal canal involvement by tumor, where inguinal nodes are felt to be a drainage basin in the setting of canal involvement. That is somewhat controversial, as the risk of isolated inguinal nodal failure, even in patients who do have canal involvement, is still very low. So why then is there some reluctance for short course radiation in the US at least? Historically, it's felt that perhaps long course chemoradiation has a higher pathologic complete response rate. But that actually probably stems from these historic differences in the timing of surgery. We talked about how Stockholm 3 leads us to now adopt short course with delay, but historically that wasn't true. It was often immediate. And whereas long course chemoradiation, a delay was more standard. And so you did historically see a higher pathologic complete response rate with long course because of that delay. Therefore, surgeons often felt that it was easier to operate because of that response. And we do know that long-term outcomes are correlated with the path-CR rate. However, when we look at Stockholm 3 again, we actually find that the path-CR rate correlation with long-term outcomes does appear accurate. So it is important to have patients have a path-CR. But that if we have a same delay with short course before surgery as we do with long course, the short course path-CR rate is actually not worse. It's very similar to historic rates of pathologic complete response, 12% here, for long course chemoradiation. And you see that here. So why still the reluctance? Sometimes in the US, people perceive that short course has worsened late toxicity and maybe worsened acute toxicity. But again, both the Polish 2 trial and Trans-Tasman showed no worsened late toxicity in randomized comparisons. And Stockholm 3 showed no difference in acute toxicity. So maybe it's just that old habits die hard, or our surgeons are dictating what we're doing. Or in the US, perhaps it's a financial factor of reimbursement models, although I hesitate to write that on the slide. So overall, short course radiation is entirely acceptable in the treatment of rectal cancer with perhaps a couple of thoughtful caveats. Total neoadjuvant radiation and chemotherapy has also arrived to stay. So how and why? So first of all, adjuvant chemotherapy, again, the data for it directly for rectal cancer are somewhat lacking, but we adopt the data from colon cancer, which is, of course, very identical disease process, different geographic location in the colorectum. It does improve overall survival in that setting. And oxaliplatin further improves outcomes. And so FOLFOX is that standard. So why total neoadjuvant treatment if we've done adjuvant therapy? One of the big factors is that you're waiting 6 weeks for your surgery anyways for toxicity reduction as well as that radiation response. So what are you going to do with that time? You might as well start filling it with chemo, perhaps. But most importantly, we talked about how there was that big delay, especially with long course chemoradiation, before you ever get micrometastatic coverage, at least 4 months optimistically before those patients get chemo if it's given adjuvantly. However, if you move chemotherapy ahead of surgery, then you get your micrometastatic disease coverage much sooner. Even with adjuvant chemo, disease recurrence is 2 times higher outside of than in the pelvis. So it is really important. And also adjuvant chemotherapy is hard. These patients are having big operations, especially if they're getting an APR. And multiple studies show us that the vast majority of patients don't actually receive or even start their adjuvant chemotherapy as planned. And so total neoadjuvant therapy, defined very simply, is just getting all of the radiation and chemotherapy that you're planned to get ahead of any surgical evaluation. And so at WashU, we use total neoadjuvant therapy with short course radiation. So that's on the basis of a historic trial that we ran, which was a phase 2 study showing that patients could get short course followed by about 4 months of FOLFOX chemotherapy and then their surgery. And having TNT has improved the path-CR rate compared to historic controls. Importantly, the toxicity was really similar. The only thing that was different was that there was more pre-op hematologic toxicity, which is very sensible as chemo is given preoperatively in this setting. So overall, safe with improved path-CR rates and better downstaging. And that, of course, has been recapitulated in the much larger and impactful Rapido phase 3 randomized trial that we're probably all quite familiar with at this point. So this was giving short course radiation followed by FOLFOX or CAPOX, followed by surgery versus the historic control paradigm, which was long course chemoradiation, surgery, and adjuvant chemotherapy. The important thing to mention is that although these two arms had different radiation paradigms, really radiation was not part of the question here. And the primary endpoint was disease-related treatment failure. Key things to point out in the eligibility is these patients were really high risk. They were intentionally selected to be very high-risk patients. T4 and 2 disease or high-risk features like mesorectal fascia involvement, enlarged lateral sidewall lymph nodes, extramural vascular invasion, so high-risk population. And the reason for that was because when you're looking at disease-related treatment failures, that's anticipated to be a metastasis rate. And so you want to select patients who are at high risk of metastasis to start with. And so in terms of outcomes, patients did similarly for tolerance between the two arms. Things related potentially to radiation were essentially identical between the two arms, but the disease outcomes were very distinct. So there was a 7% reduction in disease-related treatment failure, and you see that here, which was driven primarily by the same reduction in a distant metastasis rate. There was no difference in local failure between these two groups, at least in the initial data, although the later data have indicated some higher rate of presacral failures in the TNT approach. So initially, no difference in local regional failure, although, like I mentioned, a higher rate of presacral failure in TNT, but a drastically different path-CR rate as well. So questions and criticisms about Rapido: adjuvant chemotherapy was optional in the standard arm. However, on subset analysis, which has the limitations of subset analyses, lack of adjuvant chemo did not affect the probability of having disease-related treatment failure. And then also it's a high-risk cohort by design. So it doesn't give us explicit instructions for what are we supposed to do with lower risk patients. Fortunately, PREDIGE 23 provides that answer, at least to an extent. PREDIGE 23 was a study of patients who had some lower risk disease, so included node-negative patients, patients with T3 disease. And this was a study of TNT with 6 cycles modified FOLFIRINOX, followed by long course chemo-RT versus long course chemo-RT surgery and adjuvant. And you can see again that disease-free survival, which was the primary endpoint, was improved. Overall survival was not different in this, again, likely because this is a lower risk patient cohort. Adjuvant chemotherapy was mandated in both arms, which is important because that was a criticism of Rapido. And still, and there was good compliance. So these results hold a bit more in that you have a DFS improvement by doing total neoadjuvant treatment. And similarly, with Rapido, we see that that DFS endpoint is driven by this reduction in distant metastases. Important to our surgical friends, there is not any change in post-op morbidity or post-op length of stay when you do total neoadjuvant treatment versus adjuvant chemo. And of course, again, the path-CR rate is significantly improved. So total neoadjuvant treatment, in my opinion, at this point is entirely here to stay. And similar path-CR rate here as with Rapido as well. One thing that is really quite brand new is the considerations for patients who are mismatch repair deficient. So patients with Lynch syndrome or Lynch-like genetics. So this was a phase 2 trial run at Memorial Sloan Kettering Cancer Center in New York, of giving single-agent dostarlimab, which is an anti-PD-1 monoclonal antibody, every 3 weeks for 6 months in stage 2 and 3 rectal adenocarcinomas. And these patients were actually anticipated to require subsequent chemo, radiation, and surgery. Historically, Lynch-like patients have the worst outcomes in colorectal cancer. So we were ready to throw everything at them. However, what happened was during dostarlimab, all patients in this study actually had a clinical complete response. And you can see an example of that here from one of the patients from the study, where they clearly have fulminant disease initially, and then it is resolved by 3 months. And that resolution actually persisted. Still to this point, none of the patients on this study have had a recurrence of their disease, which is really, really quite impressive. And now, of course, larger trials are underway, and this will very likely soon become standard of care. This is obviously a very small trial, but very, very striking outcomes. Okay, so total neoadjuvant is here and not leaving. What about non-operative management? So you can see the origins of non-operative management when you look at total neoadjuvant therapy. We're starting to see these higher rates of pathologic complete response, nearly a third of our patients, clinical complete responses, and all of these things are prompting the question of, well, do we have to do surgery in somebody who doesn't have any detectable tumor? TNT, again, has really increased that path-CR rate, which is a great prognosis, but it's really hard to tell a patient after their surgery that there was no tumor left. Some patients are happy to know that, oh great, it was all gone. Other patients are very angry. I got surgery and there wasn't even any tumor there. And so it may be overtreatment in these patients. And so non-operative management is very interesting. And there's a reason for it. When you go back to the Dutch trial that we looked at earlier, and we were happy to see that radiation improved local control, what we're also seeing is that in these trimodality patients, there's huge rates of incontinence and significantly quality of life impacting outcomes when we have to do multimodality therapy. And so there is a need to do fewer things to our patients if we can. So the origin of non-operative management is actually in Brazil with Dr. Habergama. And so she evaluated patients who were treated with preoperative chemoradiation and found that about a third of those patients had a clinical complete response, not a path-CR, but a clinical complete response. Even with long follow-up, what they found was that in those patients, if they just managed them with very watchful waiting, local recurrence was uncommon and could be salvaged locally when it occurred. Distant metastases occurred at similar rates to patients who got surgery. And overall survival was still really excellent. And so they have since published their results in multiple retrospective studies that all show this same idea, which is that patients who have a clinical complete response can be observed rather than taken to surgery, and that they continue to have the excellent outcomes that you would expect out of patients who have such a good response to start with. So what about using short course radiation? That was all long course. So at WashU, we ran a phase 1 trial called the Normal-R study of giving total neoadjuvant treatment with short course radiation. And if patients had a clinical complete response, they underwent non-operative surveillance, which was colonoscopy and pelvic MRI every 3 months, in addition to traditional Q6 month CT restaging. The primary endpoint was, of course, clinical complete response. High-risk patients were excluded, as were patients who had tumors really far from the verge, where it's more difficult to carefully manage them or evaluate their response with scoping or exam. And what we found was that the clinical complete response rate was really quite high. It was 67%. And most patients had sustained response. Although similar to the Habergama data, there is a set of patients, about a third of those who have initially a clinical complete response will develop local tumor regrowth, usually about a year after their completion of treatment. But all of those patients were salvageable with TME. And like you would expect and hope to see, those patients still actually had better 2-year DFS than patients who didn't have a clinical complete response, which is good. These patients should have better outcomes. They're having really good responses. Historically, these are our patients who are doing really well. So we don't want to lose that by doing non-operative management. And anorectal function and quality of life scores were really good in patients who are able to avoid surgery, which is a goal. So we're now accruing to a phase 2 multi-institutional trial of non-operative management using this same paradigm with a primary endpoint, again, of clinical complete response rates, but a much larger multi-institutional trial. Does the order of delivery of treatment in total neoadjuvant therapy matter? Should you do chemo first, or should you do radiation or chemoradiation first? The OPRA trial gives us a fairly clear answer to that, although it's a phase 2 trial. This was a study of patients with distal rectal cancers, stage 2 to 3, large study, and patients were in 2 arms. One got induction chemotherapy followed by long course chemoradiation, and the other got the opposite, which was long course chemoradiation first, then chemo. And then at the end of the total neoadjuvant treatment, both sets of patients were evaluated for organ preservation, in other words, non-operative management. And what they were trying to show was just that overall, all of the patients in both arms would do well and be able to have selective non-operative management. They weren't actually comparing these 2 arms, at least not technically. But we did end up finding, or they did end up finding, that those patients who had their radiation first, who had chemoradiation before chemotherapy, had a greater TME-free survival, significantly more clinical complete response than patients who had chemotherapy first and got the radiation second. So this tells us that chemoradiation or radiation treatment should come first, followed by chemotherapy, if especially you're hoping to have organ preservation, but also in terms of the overall response rates. They updated these results at ASCO a year later. Both of these, this was initially presented as ASCO data both times. And the 3-year rate in their patients who initially had a clinical complete response in either arm of being able to avoid a TME was about 80%. 20% or so of patients ended up needing a salvage surgery with local regrowth. But again, most importantly, these patients who had clinical complete responses are still having the best DFS and OS. So you're not losing ground, and in fact, they're behaving like they should, which is the best of anybody since they're having the best responses initially. So one thing to keep in mind is that non-operative management in practice requires patient compliance. These are the patients that you want to make sure are reliable, can come back for follow-up, have tumors that can be surveilled. This is our paradigm for how we follow these patients at WashU. Again, they get a flexible sigmoidoscopy and a pelvic MRI every 3 months to very carefully monitor for either endoluminal or other pelvic regrowth. And then their chest and abdomen, actually is what the CT should read, scans are every 6 months, which is standard after surgery. So really carefully watching these patients and taking them to surgery at the first sign of potential regrowth. So overall, radiation before chemo and TNT will likely improve response rates. Short course can be used in all of these settings, and including in non-operative management. Order of treatment does affect clinical complete response rate, but doesn't seem to change survival rates. Long-term outcomes for things like non-operative management are pending, but non-groups are not faring worse. So it's worth pursuing, and many follow-up studies are underway.